This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, a senior attending in neurosurgery, and I'm joined as always by our research fellow.
And I'm Dr. Ilara. Today, we're looking at a fascinating new study from the Journal of the American Heart Association, published in 2026. The paper is titled, Impact of Readmission Hospital Site on Outcomes in Patients with Intracerebral Hemorrhage Undergoing Surgery, a Nationwide Cohort Study.
This is a critical topic for those of us in the OR and the ICU. We know that patients with intracerebral hemorrhage, or ICH, who undergo major neurosurgical procedures are among the most complex patients we manage. They are at high risk for complications and, unfortunately, early readmission.
Exactly, Dr. Aris. This study really focuses on that post-discharge window. The researchers wanted to evaluate the association between the readmission hospital site, meaning whether a patient returns to the index hospital where their surgery was performed or a non-index hospital, and their subsequent outcomes.
That's a variable we don't always talk about during rounds. When we discharge an ICH patient, we hope they'll follow up with us. But in the real world, emergency readmissions often happen at the nearest facility. Ilara, let's talk about the study design. This was a nationwide cohort study, which gives it significant power.
Right. By using a nationwide cohort, they were able to capture a massive snapshot of how these patients fare across different healthcare systems. The primary focus was on those ICH patients who had already undergone a major neurosurgical procedure. They aren't just looking at medical ICH, they're looking at the surgical cohort, the patients you and your colleagues are operating on.
And those surgical patients are particularly high risk. When we talk about major neurosurgical procedures in the context of ICH, we're talking about craniotomies for clot evacuation, decompressive hemicraniectomies, or perhaps even EVD placements followed by more definitive interventions. These patients have a high complication burden. Why is the index versus non-index distinction so important here?
The study suggests that the site of readmission significantly impacts outcomes. When a patient returns to the index hospital, the place where the surgery was actually performed, they're returning to the team that knows the nuances of their case, their surgical anatomy, and their immediate postoperative course. In contrast, a non-index hospital might not have access to that specific surgical history or the same level of neurosurgical subspecialty care.
It's about the continuity of care. If I perform a craniotomy on a patient and they come back to my ER with a headache or a focal deficit, I know exactly where the bone flap is, what the intraoperative tension was like, and what the post-op imaging showed. A non-index hospital is essentially starting from scratch. Did the study highlight specific outcomes?
Yes, the study aimed to evaluate that hospital site and patient outcomes, specifically mortality and the severity of complications. The abstract notes that because these patients are at such high risk for early readmission, where they end up matters for their survival and recovery.
It's a systemic issue. For the residents listening, this highlights why our discharge summaries and communication with primary care and local hospitals are so vital. If the data shows that non-index readmissions have different outcomes, it suggests we need better integration between primary stroke centers and the comprehensive centers where the surgeries happen.
And for medical students, it's a reminder that neurosurgical care doesn't end when the skin is closed or even when the patient leaves the ward. This nationwide cohort study approach really underscores that the early readmission phase is a high-stakes period. The study notes these patients are at high risk for complications, which can range from postoperative infections to recurrent hemorrhage or systemic issues like VTE.
Let's dive deeper into the index hospital concept. In a nationwide study like this, index hospital usually refers to the high-volume centers capable of performing these major procedures. If a patient is readmitted to a non-index hospital that perhaps doesn't have 24/7 neurosurgical coverage, the impact of readmission hospital site becomes even more pronounced.
That's a great point. The study's focus on ICH patients undergoing surgery is key because their needs are so specific. If you've had a major neurosurgical procedure, a readmission for something as simple as altered mental status requires a very different workup than it would for a general medical patient.
Absolutely. You're looking for shunt malfunctions, subdural hygromas, or seizure activity. If you aren't at the index site, those neurosurgical nuances might be missed.
To summarize the core of the paper for our listeners, this was a nationwide cohort study that found a clear association between where an ICH surgery patient is readmitted and how they fare. Returning to the index hospital where the surgery was performed is a major factor in patient outcomes.
It's a call to action for better hub and spoke models in neurosurgery. We need to ensure that no matter where the patient is readmitted, the expertise and the data from the index surgery follow them.
Exactly. It's about closing the loop in the postoperative period.
Well, that's all the time we have for today's episode. A big thank you to the authors of this study and the Journal of the American Heart Association for shedding light on such a critical aspect of post-surgical care.
Thanks for listening to the Neurosurgery Hub podcast. We'll see you in the next episode.
Until next time.